Hello everyone, this is Ali, one of the pediatric residents in Texas Tech, El Paso. And today we'll talk about an interesting topic. I was reading about it and I found that it is very interesting to me. I thought this is going to be a very short kind of talk through. I was interested in one of the patients on a ventilator, and I was speaking to one of my PICU attendings, and the main discussion was about cardiopulmonary interactions, and I was interested about the ventricular interdependence and the ventricular-arterial decoupling. And how can I apply such physiological changes to a patient that I'm having on a ventilator in the ICU? What am I expecting to see? So I'll briefly talk about the cardiopulmonary interactions. I'll honestly be very brief and about the basics of it. I'll also attach the references, the topics about the cardiopulmonary interactions, about that ventricular interdependence and the bowing of the ventricular septum, about the ventricular-arterial decoupling. So let's begin. So the way I like to differentiate it is this. So there's two affection of it. There's one that is basically we're talking about spontaneous breathing versus pressure breathing. So if a patient is having spontaneous ventilation versus positive pressure ventilation, how is the pressure changes and how is the cardiac effect by those ventilatory modes? So think of it this way. So we're having this lung over here. And a patient takes this is the diaphragm. And a patient takes a spontaneous breath. When a patient takes a spontaneous breath, what happens? There's decrease in the intrathoracic pressure. So when you take a deep breath, there's a decrease in the intrathoracic pressure, which leads to increase in your venous return. Basically, that decrease in intrathoracic pressure helps pull all of that venous return back into the thoracic cavity to go under the right side. So when that happens and there's an increase in the venous return, you'll see that there is decrease in the left ventricular ejection because the pressures are against the pump. So everything is going into the heart, so whatever is coming outside of the heart is actually decreased. So there's the decrease in the left ventricular ejection, and with the increase in the left ventricular decrease in the intrathoracic pressure, there is a decrease in the atrial pressures. That decrease in the atrial pressures help that venous return pressure to go back and fall into the right atria. That being said, what happens into the abdominal cavity? There is an increase in the intra-abdominal pressure. When you take a deep breath, the thoracic pressure decreases, but the abdominal pressure increases to help pump all of that venous return, which means there's also increase in the afterload, because all of the abdominal pressure is a pressure against the aorta, which is a pressure against the left ventricle, hence why there's also decrease in the left ventricular ejection. How is that different than when I'm having a positive pressure ventilation? When there's a positive pressure ventilation, there's actually an increase in the intrathoracic pressure, right? Because you're giving positive pressure to these patients, which in turn will lead to a decrease in the venous return. That decrease in the venous return and increase in the intrathoracic pressure will lead to an increase in the left ventricular ejection and a decrease in the atrial pressure. Regardless, which means if there's an increase in the left ventricular ejection, this is an increase in the cardiac output. I'm sorry, ignore this. there's an increase in the left ventricular ejection, which leads to an increase in the cardiac output. That increase in the cardiac output, because of the increase in left ejection fraction, expect because of that increase in the thoracic pressure, there's a decrease in the abdominal pressure, there's a decrease in the left ventricular afterload. Quite the opposite of what happened here, right? So basically what happens is you give them pressure, there's an increase in intrathoracic pressure that compromises the venous return, helps that pressure. Imagine it putting external pressure on the left ventricle to help more with the ejection and the left ventricular ejection, which will lead to an increase in cardiac output and a decrease in the left ventricular afterload. So when you are weaning a patient off the positive pressure or the mechanical ventilation, which you're putting them to spontaneous ventilation, basically what you're doing is doing a selective left ventricular stress test, right? So you're stopped helping the left ventricle with increased cardiac output and putting not more strain, but you're putting it to a test solely with its spontaneous breathing. So when that happens at times, we're talking mainly about pediatric patients, but let's talk about adults or geriatric patients or patients with cardiac conditions in general. This weaning, if you're not able to know the cardiac capabilities of your patient and the ejection fractions of those patients, it can cause a weaning-induced left ventricular ischemia because of that left ventricular stress. And you need to know that weaning can cause left ventricular failure and pulmonary edema. If you're weaning too fast, if you're weaning wrong in a patient that is predisposed to have those complications. So basically, when you are doing, for example, trials to help the patient off the ventilation and you are giving them the CPAP trials, what you're doing is you're increasing that respiratory muscle's strength. You help with the left ventricular contractions and putting this over and over every night for a patient to help them on a CPAP trial. You also decrease that serum catecholamines, which will cause that strain on the heart as well, because basically what you're doing is you're training the heart every single day for that spontaneous breathing shift from that positive pressure ventilation that you're having. And one of the things that people also monitor, if you are worried about how the patient will respond to fluids or what kind of shock the patient is while you're weaning them, or so basically what you're doing a functional hemodynamic monitoring. And when you do a functional hemodynamic monitoring, basically what you're doing on a ventilator is you are decreasing the tidal volumes on a vent and looking at the IVC by your ultrasound to see if this IVC is a fluid responsive or not. So you decrease your tidal volumes, give them fluids, and you see if there's an IVC. There's a whole talk about how to measure IVC fluid responsiveness with an ultrasound guided AV to a different day. But I just found that this is an interesting topic to discuss and to sum things up again in the last minute, is basically to understand the difference between a cardiopulmonary interactions is basically spontaneous breathing, just that you're a routine patient. Once you take a deep breath, as we all know, decreasing your intrathoracic pressure helps your venous return go back. There's an increased intra-abdominal pressure, also helps with that venous return. But in return, that increases the afterload pressures and decreases the left ventricular ejection. And there's left atrial pressure that also works well with the decreased venous return and the increased intrathoracic pressure. However, when you're putting that patient on positive pressure ventilation, imagine all of that pressures coming on the heart, there's an increased intrathoracic pressure, pumps on strains on the left ventricle, which helps with the ejection fraction, increasing the cardiac output. There's a decreased venous return because of that pressure resistance in the thoracic cavity, and there's decreased left ventricular afterload. All of that being said, when you're weaning that pressures off to spontaneous ventilation, you know that these patients will have selective left ventricular stress. If these patients have a compromise of having that, you need to be aware that there might be a weaning-induced left ventricular ischemia. There's a left ventricular failure that can happen, pulmonary edema that is happening in patients that are predisposed for it. When you're doing when you want to check if that patient shock on a ventilator is responsive or not, you can do the ultrasound guided. You look at your IVCs and you can see the fluid responsive on it. Decreasing that tidal volume helps a lot with relieving that pressures on the heart and seeing if this is a cardiogenic shock versus a hypovolemic shock and how the IVC interacts to your fluid resuscitation. This is just basics about it. It's so much complicated in general. I try to simplify things. I'll put a link to the article for people that are interested to read more about it. And then we can discuss the ventricular-arterial decoupling and the ventricular interdependence later on. I'll just add the references down there if people like to read them, because I think it's all one topic that should be read all together, in my opinion. Thank you.